Our chairperson, the esteemed chairperson with us is Dr. Mayuri ma'am, Dr. Ronnie Joss sir, Dr. Beena Gobinath, Dr. Pooja, and Dr. Prashant. Myself, Dr. Shweta Tripathi, and my co-moderator, Dr. Naga Lakshmi, are there to solve your queries, putting it forward to the chairpersons. So today we are having 5 basic glaucoma procedures which we are going to cover. So to start with all, I would like to call upon our first speaker, Dr. Parag Sharma. Dr. Parag Sharma. Still we have got 2 minutes to go.
May I know whether all the presentations are loaded or not? Do you have all the presentations?
We have presentation Mohammed Abdul and Dr. Pallavi.
The rest of
Abdul Khairab and Pallavi. Dr. Pallavi.
it's not having please timing out everything. If you want me to load again, you have loaded in the morning.
Is a very well-known name in the field of glaucoma. So any queries regarding anything, you can ask ma'am freely. So ma'am, on yours.
It's for camera.
Oh,
Because your face is not face camera.
Good afternoon, everyone. We will start with my topic as the first 2 speakers are yet to arrive. So I will start the optic disc assessment tips for how to assess it. It's not advanced. Yeah, so you have to do careful examination and keep an open mind. So because whatever you see like glaucoma may not be a glaucoma at all. Evaluation of optic nerve head and RNFL requires a systematic approach. It improves the detection of glaucoma. ONH science is a high sensitive and specificity, high sensitivity and specificity for diagnosis of glaucoma. So clinical evaluation can be done with direct ophthalmoscopy, but it has a limited advantage. It lacks stereopsis. Stereoscopic examination can be done by slit lamp and non-contact lenses, particularly 78D or 90D, which are preferred. And you can use central part of Goldman size and size 4 mirror also. Detailed drawing is always helpful. Baseline documentation is needed. You can have color and red-free photographs, stereo photographs if it is possible. Stereo photographs early, the help in early detection of glaucoma. Normal ONH we know follows IS-centimeters. So the cup is horizontal as compared to vertical. How to identify cup margin and neuroretinal rim? So you need to identify the age of the disc, that is scleral ring. Follow the course of the blood vessels within the optic disc and identify the inner cup margin. So again, identify the age of the disc, observe the blood vessels, how they come over the neuroretinal rim, and then you will be able to identify the inner cup. The next clue is the circumciliary vessel, because normally they are on the inner margin of the cup, that is NRR, and you will be able to find out the NRR very clearly. So there are various signs of glaucoma. The physical signs of optic nerve size and shape are important. We may have different type of optic disc in normal population. So normal small disc will have a small cup, medium disc will have a medium cup, and a larger disc will have a large cup, which affects the neuroretinal rim when we evaluate. So small disc, how to identify them? So you first identify fovea central disc and the disc diameter, the cup, that is the circle over the optic nerve, and find out the disc diameter. And if the disc diameter is around 3, this can be a small disc. A medium disc will have a disc diameter of around 2, and if it is less than 2, this can be a large disc with a large cup. So whenever there is a high CD, you need to investigate. Do not label immediately as glaucoma, but because this can be totally normal. Myopia also looks like glaucoma but may not be glaucoma, so you need to investigate. Maybe you have to do serial documentation of perimetry like this and conclude. Myopic dentate disc is again mistaken as thin NRR because of the atrophy, also temporal atrophy, but you need to document and have serial photographs. Dentate disc syndrome is a syndrome where there are discs are obliquely inserted and you can get a peripapillary like thing inferiorly. So this is a syndrome and definitely not glaucoma. This asymmetry can be a initial sign of glaucoma, but in a unilateral large disc and a large cup can be totally normal, whereas same disc size and a large cup with thin NRR can be abnormal. Vertical enlargement of a cup in a vertically oval disc can be totally normal, but if a vertical cup thin NRR along with a RNFL thinning like this, superior temporal it can be glaucoma. So pallar cup discrepancy is a pathognomonic sign, and you need to identify the pallar and cup, and if it is associated with inferior temporal thinning of RNFL, this is definitely glaucoma. Cupping more than pallar, as you see here, and pallar more than cupping you need to distinguish. Cupping more definitely is glaucoma, but pallar more may not be glaucoma. So here rim pallar in glaucoma is very rare, and you need to identify and evaluate this disc. This was a Ayurvedic physician who was on glaucoma and glaucoma drugs, and his perimetry and visual field defects were like this. But when MRI did, we found different findings in this, and this is definitely not a glaucoma. Concentric atrophy can occur because of the enlargement of the cup, and laminar dot sign can be seen as a fenestration in glaucoma because of loss of neuronal tissue. This is advanced cupping where you see pallar less than cupping, and very advanced glaucoma also you can see the thinning of NRR. Coming to vascular signs, there can be significant finding, and first sign of glaucomatous damage common in inferior temporal quadrant, and they need more aggressive therapy. If you see this, more found in patients with non-potential glaucoma. So bayoneting is a common sign where the optic retinal vessel, when they traverse the optic NRR, got different almost 90 degree where there is an optic fade. So this is called as bayoneting. Bearing of circumlinear vessel, we have seen. Overpass cupping is when the vessels bridge over the cup and suddenly collapse into the cup. So this is a NVD, and this is disc hemorrhage, which is glaucoma. This is bayoneting with a large cup, and this is definitely a thinning of NRR with notching, which is glaucoma. This is circumlinear vessel, which is normal, and this is bearing, which is glaucoma. So coming to peripapillary changes, there can be slit defects like this, which can be totally normal. Sometimes the slit defects are more, and they like coalesce and can form a defect. And this is a typical superior and inferior wedge defect. So diffuse RNFL loss is seen in these patients. So normal lineage, you see this, but if you see the RNFL, you see that there is a page depth large defect. So you have to see the RNFL and inhaler very carefully. Peripapillary atrophy, alpha zone atrophy is common and seen in almost all normal patients, but beta zone atrophy can be seen in patients with POAG and NTG, and it corresponds with the visual fields. So this is the beta atrophy which is seen in myopia. This is moderate glaucoma and advanced glaucoma. This is normal, this peripapillary atrophy. If you see the visual field and OCT, you can make out that the OCT also shows thinning and visual fields show the blind spot. But this is because of the inferior peripapillary atrophy and definitely not glaucoma. Watch for progression. Watch for all the signs. If you can see, there is a splinter hemorrhage over here, and which is developing into the RNFL defect. So again here a small RNFL defect superiorly, but now there is a development of disc hemorrhage along with the inferior defect, and the left eye also the RNFL ratio defect is usually outside. The various optic nerves which we call as anomalies, and here we cannot differentiate whether they have glaucoma or not. So coming to the different size, focal atrophy, wearing of circumlunar vessels, laminate oxide, and inferiorly again, wearing, thinning of inhaler, and alarm. So documentation is very important, which process will help you. And don't forget comorbidities, because these patients are all elderly patients and they can have certainly some other diseases. Do not ignore large drops, because they might be normal, might be having advanced glaucoma, might be having some neurological problems. So most important is note the disc size. NRR is important and not the CD. Check for Pellar discrepancy, find and observe vascular signs, evaluate RNFL defects, note the signs of progression, keep a high level of suspicion when the findings are atypical, and remember that patient may have more than one disease. Keep in mind that everything that looks like glaucoma may not be glaucoma. Thank you.
Thank you, ma'am, for highlighting the finer details of this assessment, which forms the basic tool of glaucoma diagnostic armamentarium. With this, I would request Ronnie sir to give his tips for assessing a mild disc for the beginners.
Assessing a myopic disc is difficult not only for beginners, it's difficult for glaucoma surgeons also. And I think what's really important is to follow the rules that Madam has just said. So if you manage to isolate where the rim is, and then after that you look at the edge, making a careful documentation in that disc is really important. If there is a definite visual field defect with nothing on the retina to explain it, then the damage is probably related to glaucoma. If you're seeing some defects on the retina, but it is also, you're seeing some defects on the field, but you're seeing also retinal changes in that area, you're not sure. So that is a situation where you become worried about whether this is actually glaucomatous or not. So then it's very important to document, either do a detailed disc drawing or take serial disc photographs. Those are the two best ways of assessing myopic disc.
Which is the method you suggest for the general ophthalmologist to document things? Is the drawing enough, or they have to document with the photograph?
If you have trained in a center which insisted that you draw every single disc from the beginning, then this drawing is not bad. But it has been shown repeatedly that it is not as good as a photograph.
Thank you very much. So if there are any more questions, you can write it down with yourself and we can take it at the end of the presentation. And with that, we move forward with the next presenter for the day. That's Dr. Parag Sharma, who is going to tell us something about the Goldman apprenticeship tonometry, including the most important part, that sterilization and calibration. So till he is getting ready with his presentation, we can have some more questions.
We will take all the questions at the end. One question after each talk, and then the rest will be taken later. Parag, you may start.
We are having with us Dr. Mohiddin Abdul Qadir sir, who is going to give us some tips to be followed for gonioscopy. That's again one of the, I would say that is the best friend in your glaucoma clinics. Gonioscopy, you cannot shy away from gonioscopy if you are assessing a glaucoma patient.
There's the infections after this population.
Yeah. Okay, now. Yeah. I think colonoscopy is the third one. Like we do a night examination, then appellation, then the colonoscopy is the third one. So the colonoscopy, let's see how. Just give a small case scenario. It's only a boy.
Direction going to
History
change
of
because there is very hot. They are not able to sit.
A person with computer defective is a right eye since 4 months.
Please change.
Then he came with a vision of 660 right eye and 6/6 left eye, and this corresponding to near vision in 36. So in the clear cornea, deep chamber, and PCO thick next PCO, one is normal, ICAR is 18. So left is normal. So he underwent a AIOC capsulotomy and around 1.2 millijoules for 36 hours because of they put him on moxifloxacin dexamethasone 6 times a day, and astaxanthin given 1 BD for 3 days, and he was asked to go. But he proceeded 3 hours later to the vision center. This comes a severe eye pain and associated headache. And epidural edema processed 15 in 3 hours of capsulotomy, and they started Diagnostics and they referred to the base hospital again. So he was admitted and gave to IV mannitol, acetazolamide. Steroids was continued. They started a cyclopathy of macular glaucoma. So day 2 they referred us for glaucoma clinic of opinion. So this is a typical case of an epidural edema and Flaren's cells 1+, PCOIL, and IOP 15 in the PC opening. So what do you want to do? I told my look at the gonio. So gonioscopy clearly says what the diagnosis. I think the angle recession. I think the 360 angle recession he had, so, but he didn't have a pressure hike before capsulotomy. He still responded. So when he stopped steroids, then within 1 or 2 days the pressure came down, it became normal. So I think gonioscopy is important fundamental part of any component examination. The basic purpose is to determine the top of the antechamber angle. So what are the landmarks you see? You see a solid-based line which is more anterior. Then you have the tubercular measure, you have pigmented and non-pigmented one. There are slums now the deeper the tubercular measure. You have ciliary spur, and you have ciliary body and iris processes. So this is a typical gonioscopy point. You see solid-based line which is the pigmented line. Then you see a tubercular measure, non-pigmented, then pigmented. Then you see a spur, then see this is the order normally we see in an angle. So slums are normally not visible because like deeper to the posterior tubercular measure. Whenever you put too much of corneal pressure, cutting a fistula, Sturgeon syndrome, venous hypertony, you can see a blood in slums canal. So what normally this is like class because we follow a safer system based on the angle to the angle basis. Normally we say grade 0, 1, 2, we normally they will say the 2 is an occludable angle, the 1, 0, 1 is a closed one, and 3 is a normal one. Normally we say depend on the angle width. The angle with more than 3 we say or more than 20 to 30 to 35 degree, and 4 is 35 to 45 degree. And this is a typical diagramic book is given, so the grade 0 and 1. See the grade 0, you know that the angle wedge doesn't meet. When the two wedges meet, they correspond to the solid-based line. So this is the way normally we all of us will follow. What is slit angle? The no obvious vertical contact, but the no angles are identified. Slit angle, extremely high closure cases. Okay. What directly we see in entire gonioscopy, we use a slit lamp. We have two techniques: indentation, without indentation. And what are the lenses we use? A Goldman 2 mirror, a single mirror, or you use 4 mirror, post panel, 4 mirrors. What are the difference between 2 mirror and 4 mirror? A 2 mirror, the central wall is center is 12 millimeter, the convex is 12 millimeter, and the mirrors inclined 62 degree, especially in a 2 mirror, is 64 in a 4 mirror, and the radius of inner surface is 7.4 in a 2 mirror, and here is 7.7 is equal to cornea. So this allows the tears to use the coupling solution. So what are the artifacts you avoid? You try to make a small slit beam, 2 to 3 millimeter, avoiding to the center of the car people because you can avoid less transection, pubic transection, less illumination. Use a Goldman 2 mirror, try to avoid indenting peripheral cornea. If you're using a size 4 mirror or a Sussman or Posner, avoid pressing to the central cornea, you cannot even avoid the angle. So what is the plateau iris? Typically you see a double is double hump pattern, basically in anterior portion ciliary process, which causes the peripheral to the ankle, the plateau iris. The plateau iris, along with dilatation, causes high pressure. After PI, we say plateau iris syndrome. So this is typical creeping angle glaucoma. See, typically it looks like a mimic like an open angle glaucoma. Unless you do gonioscopy, see one part of the angle is open and one part of the angle is closed. This is like a zip. Unless it is very difficult to find out. And the angle neocells, which is external angle of the solid scalar spur, otherwise with tubercular measure, they are fine and they are superficial, branching and unseen. And what is sacral dialysis? Normally, this is associated with a scleral spur. Directly you see a sclera, a deep angle, hypotony, and white color of the angle. So, what is the indentation goniostomy going to help you find? So, look at the figure 1. The angle is closed. You try to push the lens, the indentation. What happens? Angle opens. So, what we'll say? It gets some opposite angle closure. Okay. The figure number 3. You push again, but the angle doesn't open. The sinic is there. You say sinic line closure. Figure number 4. You push again, but angle is little opening, but not enough. See, look at the lens thickness of the figure 4. The more thicker anteroposterior lens thickness. The culprit is the lens. Here, the scenario 4, you have to remove the lens. The scenario 1 and 2 and 3, you do the AIOC. So, depending upon the mechanism, give the mechanism what the cause of an ankylosing glaucoma. We just see an indentation goniostomy video. This is a case of a narrow angle with a PX1, and see the Van is there. We want to do. Then what we do, we just look at the angle. We try to indent. See, we try to indent. See the indent. You can able to see a tropical mesh work, and that means that in the case of an oppositional closure, and this definitely need an ARPA. Look at the plateau iris. This is typical of double hump pattern. See the one hump to the mid periphery, the one hump near the angle recess. This is typical of a plateau iris syndrome. So this definitely need and mostly the diagnosis after ARPA. Okay, mostly done after ARPA. So when you dilate, some pressure goes up. And next we'll see this plateau iris syndrome, and next the creeping angle. So I tell you, so one area is closed. See this area, what you see is the pigmented solid line, and this is the pigmented tuberculation. So if you use a corneal wedge, you definitely know which is the pigmentation of solid line, which is the tuberculation. The corneal wedge is very important, especially narrow angle. So you see two demarcation. The one angle is closed and one angle is. This is the typical case of a creeping angle. Normally it is missed unless you do a gonioscopy. It's very important, especially to prevent malignant glaucoma. This is a patchy tuberculum. Sometimes you get a subacute attack. So you get something like a patchy pigmentation. This is a typical case of subacute ankylosing glaucoma. Definitely this kind of cases the need and ARPA. Then you also see a pigmented angle. Sometimes you see a lot of pigmentation angle. You see a lot of pigmentation angle. Sometimes a pigmented glaucoma, sometimes even if doing some diabetes patient, semi-peaks of glaucoma, if it's a pigmented angle.
So if you can please point us.
Yeah. So just missing it. Just how to clean these gonal lenses. Normally we use 70% alcohol sponges, and along with the chlorhexidine is available. So just first you clean the lenses with the alcohol sponges. Now after that, you clean with your normal sterile cotton, because directly do with an alcohol sponge, you can harm the cornea. So again, you just clean the one. You don't clean it, there's a lot of chance of adrenal conjunctivitis. So also alternately, you can also use 1 to 10% of household bleach sodium hypochlorite. You can just fix it for 5 minutes. So just put a few solution, especially for 2 meter, make the beam to 2 to 3 millimeter. Ask the patient look up. And no, all the patients will be cooperative. If you explain to them properly before the procedures, all the patients will be cooperative. None of the patients say uncooperative. So I just, this is the 2 meter. Again, the 4 meter, we can, after the seeing a superior and inferior mirror, just rotate, look at the nasal and inferior mirror. So again, you can just use it for even for 4 meter. 4 meter doesn't need coupling solution. You just need to directly and gonioscopy can be very important, especially as a look up and just I'm just closing. So you can also especially for GAD, the gonioscopy can be very important because we need to look at this angle and go there and look at the angle, look at the pigmented tuberculum, make a nick there, then you see a slump canal. Okay, then you see a slump canal, you deepen that area. See, you see a slump canal, then you put a suture there. This is slump canal. So once you.
Thank you very much.
Yeah.
The presentation is.
Yeah. So to conclude, I think first thing you need to buy your own gonal lens. That is very important. And this is a part of a comprehensive examination. You do at least 100 gonal examination before you say which is normal, abnormal. I say gonal is not. Thank you.
Thank you very much. Dr. Bharat. Before we start, I would like to say that gonioscopy everyone has to do in all the cases of or suspect cases of Shevler chamber, glaucoma cases. Above the age of 40, when you see any Shevler chamber in the body, it has to be done. It is a dynamic process. Every yearly it has to be repeated, or if any intervention is done, then also you have to do the gonioscopy.
Calibration. The tonometer eye test measures the inner pressure of the eye and also known as the intraocular pressure, and the tonometry is carried out by the instrument called tonometer. That we can do by the two methods, as indentation and applanation. The basic principles is applied force which either flatten or indent the cornea. The ideal tonometer should give accurate and reasonable intraocular pressure. It should be convenient to use, simple to calibrate, stable from day-to-day practice, and easier to standardize and free from the maintenance problem. So the principle is pressure inside the sphere is equal to the force required to flatten its surface divided by the area of the flattening. So, but human eye is not the ideal sphere or dry, flexible or thin. So to modify the rule, and then W plus A is equal to PA plus B. And then the cornea resists flattening and the capillary attraction of the tear registers tend to pull the tonometer towards the cornea. In the Goldman tonometer, these two forces cancel each other out of when the area of flattening is equal to 3.06 millimeter of diameter, and this causes minimal displacement of the fluid in the eye. So how we do the tonometry? Simple, just put one drop of proparacaine in the lower part of the conjunctiva. Ask patient to blink through 3-4 times, and after 20 seconds or 30 seconds, once the the eye is a topical anesthetized, then just touch the cornea, just maintain the lateral canthus in the level, and just touch the cornea, and at that time you will get the Myers, and you can get reading also. Now just rotate that, means the pressure is nearly 23. I got this in the end point. Now I will show you the another video. This is a prism. You can see this Myers, and I'm trying to make in the proper alignment. This is a little thin, so I told the patient to blink 2-3 times. Again, the fluorescence is nicely. You can get here this good Myers, and align this inner part of the upper and lower these Myers. So false low IOP you will get in a too little fluorescein or thin cornea or cornedema, or with the rule astigmatism, and high intraocular pressure in the too much fluorescein, thick cornea and stiff cornea. So how do we do the calibration? Calibration is done in the dial position of 0, 2 or 6 is equivalent to the 0, 20 or 60 millimeter of mercury. So this procedure is only intended to verify the accuracy of the instrument. If the tonometer is inaccurate at any of these dial positions, it should be returned to the manufacturer for recalibration. So I will again demonstrate through the video. So this rod, this center point is a 0, then again it's a 2 means 20 millimeter mercury, then last the tip side is a 6, you can see is a 60 millimeter mercury. Just put this in the 0 position and start calibration, and the knob should be in the 0 also, and our focus is to see the 0 and towards our prism. And movement of the prism is important. First forward, then this is little bit, yes, now this tilted again in the position 2. Now you can see this means this Goldman applanation has error, so I should send it for the company or manufacturer. Same thing we can repeat in that position 2, and again is a plus 2 or minus 2. If there is reading is there, then it is good. Beyond that, again means it has error. So how do we clean the applanation tonometer? The same thing that Dr. Sir Rohidin sir explained. So Goldman applanation prism is also wiped with the gauze soak in 70% isopropyl alcohol and then dried before use. So what are the other things? We can do dry heat and mechanical cleaning with disposable wipes. wipes with the gauze soaked in the alcohol or chemical like hydrogen peroxide or merthiolate, sometimes ultraviolet rays. These are theoretical and gas sterilization. So many of these methods may be unreliable, for the example, mechanical cleaning, and impractical, time consuming or damaging to the tonometer parts. So I should be effective. This station should be effective in removing common offending organisms like adenovirus, herpes simplex, or HIV for the instruments, and should not damage the instruments parts, for example, like plastic light scenes of the Goldman prism, and should not affect the pressure rating. So how we do the wipe? When a prepared pad or gauze soaked in 70% isopropyl alcohol is applied to the tip of the prism for 10 seconds, and then prism tip allowed to dry before use. The small video is hydrogen peroxide, and you can see this bleaching powder 99 and this alcohol. You can just take a tissue wipes or dry and just spray a little bit alcohol, isopropyl alcohol, and touch it for at least 10 seconds. The 10 second or 15 second is enough for the sterilization, and leave for the dry, and after that either you want to use, you can use it. Same thing you use for the bleaching, or 1:10 of in dilution, and touch this mixture with the prism and dry it and wash it. So the common solution is use at 1:10 dilution of household bleach, and soak the prism for 5 to 10 minutes between use. Air dry for the alcohol or irrigating tips with the saline, and dry in case of the sodium hypochlorite or hydrogen peroxide use. Thank you.
Thank you for demonstrating the basics of Goldman affiliation volumetry software. So my question is to Dr. Prashant sir. Though Goldman affiliation volumetry is considered as gold standard, what are the conditions where you look for other tonometry devices? And also, what are the additional precautions that you will be taking for seropositive cases?
In case of corneal opacity movements like eye care or tonometer,
for seropositive cases, whatever disinfection protocol you follow, just keep it for longer. And what I like to do is I like to wash the prism also. So that removes any biological material.
Thank you, sir. So next, I call upon
opportunity. I thought glaucoma is hot, but it will be so hot I never realized. So we'll talk in short about the interpretation of visual fields. So this is what a single field analysis looks like, and we divide this for the sake of analysis into various parts. The first part is the procedure information and the patient data. The second part is the reliability analysis. Then we have the raw numeric data and the grayscale. Then we have the total deviation, the numeric and the probability plot, the pattern deviation, numeric and the probability plot. We have these GHT and the visual field indices, including the VFI, and then we have the gaze tracker. So first we'll talk about the Humphrey, and then we'll talk in short about the octopus. So what this gives us is the name of the patient, because there could be various patients. The ID of the patient, there could be, sometimes two patients with the same name in your OPD. The eye to be examined, the left to the right eye, the date of birth, because the data is compared to the age matched normals. The date of the exam, because the patient can have various visual fields. The visual acuity and refractive error to be properly placed, the pupil diameter, the test strategy, because we can compare standard with standard better, the stimulus size, the type of program. This all is given in the upper part of the visual field printout. Then we talk about the various strategies. We have got 34-2, 24-2, 10-2, and then we have got 30-2C these days. Then we have the standard, fast, and the faster. Or as we move forward, we have lesser time consuming. So you have to compare the same type of strategy with the previous same type of visual fields. The fixation pointer is usually the blind spot, and it is mapped early. What perimeter does it gives another stimulus at the blind spot. If the patient says that it is seen, then it is marked as a fixation loss. Fixation target is typically a central light. Up to 20% of fixation losses are acceptable. Then we move on to the false positive. The upper limit of acceptable false positive is 15%. So what happens here is the patient does not see the stimulus but press the button. So what it gives you a very high threshold value, abnormally high sensitivity as compared to the normals. The patient is seeing very faint stimulus which is not seen by a normal person. So there is a lengthy testing. GST will show abnormally high sensitivity and there will be larger defects in the pattern plot as compared to total deviation plot. Then we move on to the false negatives. What the patient does here is he sees the patient and doesn't respond. It could be because of the fatigue or incapability. The mean deviation will show a negative high value. Also the pattern standard deviation would be pretty high. The foveal threshold, if there is a good visual acuity, poor foveal threshold, it shows early involvement of fovea. If there is a poor visual acuity, good threshold, it points towards a refractive error. Now, this is the second part, which is the raw data and the grayscale. We have to be very, very careful because the two adjacent points can't be judged on the grayscale. It can cause depression with the cataract and age, and it is not so very important from the glaucoma point of view, but it can highlight some common artifacts and make the patient realize what he is losing. Then we move on to the total deviation plot. It compares the age-matched normals with the patient. Any deviation by 5 decibels is taken as abnormal. The positive numbers indicate more and the negative numbers indicate less sensitive spots as compared to normals. And this is again a center weighted, that is center points are given more weight as compared to the peripheral ones. It is good for the overall visual assessment, overall health of the vision rather than the pattern of the vision loss. Then we move on to the pattern deviation. What visual field does is it corrects all the kind of points from the 7th most sensitive non-edge point, and it identifies the glaucomatous defects, that is the defects within the defects, as localized defects. So it removes the generalized depression because of cataract and age and bring out the glaucomatous visual field defects. So in early stages there will be subtle defects which can be easily picked up, but in the advanced cases it may be misleading. So in the end stage glaucoma, it can even be reversed. So all the plots, all the symbols which are present in the pattern deviation but absent in the total deviation plot are usually false positives. Then we have the GST, so it compares the upper half of the visual field from the lower half in the various zones. If the difference between the two zones is statistically significant, it flags it as outside the normal limit. If it is borderline, because the difference is not significant enough statistically. Generalized reduction when all the points are low as compared to normals. Abnormally high sensitivity, as I've already talked about, and then within normal limits has to be normal. Then we move on to the global indices. So all the global indices are center weighted, that is all the points in the center area are given more weightage as compared to the peripheral points. The mean deviation, if there is a deviation which is above 2 decibels, should arouse a suspicion of glaucomatous visual field defects. It is good to analyze, it helps us analyze the overall visual field performance rather than the generalized defects. Pattern gives you a small area which is more within the hill of the vision, which is more depressed within the hill of the vision, like a nasal step or a scotoma which is there because of the glaucoma. Now VFI is a single numeric metric which represents the whole visual field into a single number. A full visual field will give you 100 and a perimetrically blind patient will give you a VFI of 0. So we all know that the rate of progression could be event based or a rate based. So VFI is a combination of both, even in the rate based analysis. It usually takes into account the pattern deviation plot, but if the pattern deviation is not so good, it can take the total deviation plot also into the account. So it also gives a small value which generates a p-value for it, and p-value signifies how fast or how significant the drop is. And the correlation between the VFI and GPA in almost all kinds of glaucoma has shown to be very good. Now there are certain points we have to understand about the global indices. The cataract, high refractive error, media opacity will show as high mean deviation as compared to normal pattern standard deviation. Early glaucoma will show a low mean deviation but a high pattern standard deviation because of the focal defects. And they would be similar in both MD and the PSD plots. In cataract and glaucoma or in advanced glaucoma, the PSD would be abnormally low with abnormally low p-value. In advanced glaucomas, the PSD will improve because the hill of the vision will become very flat and all the points will go down. Now this is the gaze tracker where the patient's movements, cornea movements is recorded. So whenever the patient moves the eye, the upward line is made, and when the patient movements are unrecordable, the downward line is made. So this is how the gaze tracker works. Now we move on to the, in short, about the octopus. The octopus also has similar kind of presentation, but in different pattern. This is the 7-in-1 printout of octopus, which looks like Humphreys. So this is the procedure information and patient data. Then you have the catch trials, which are similar to the reliability indices. Then we have this raw numeric data in the grayscale, which is colored here. Then you have got comparisons in places of total deviation, corrected comparisons in places of pattern deviation. Then you have got Baby's curve and the global indices. So we talk about them in brief. So this is how the upper and the lower part of the procedure information. So we have the name of the patient, the ID of the patient, the eye examined, the date of birth, the date and time of the exam, the visual acuity, the refractive error, the pupil diameter, the test strategy, the stimulus size, and the type of the program. So almost everything is here which is similar to the Humphreys. Now, sorry. Just to skip. So this is the gross difference between the Humphreys and the Octopus. So we have standard, Sita, and Sita fast. We have here normal, dynamic, and top. So we have mean deviation, which is similar to mean deviation of Octopus. The pattern standard deviation is called as square root of loss variance. The mean deviation is called as comparisons. The pattern standard deviation is called as corrected comparisons. And GST is called as cluster analysis. So it gives you almost all the things what we have discussed in the past. So these are the strategies, like we have full threshold, dynamic, and top. So we can clearly see in the area here, the catch trials or the repetition questions and repetitions are much more in the dynamic as compared to the top area, because the dynamic is like a full threshold or a Sita standard, while this could be like a Sita fast. The reliability factor is one more point which is there in the Octopus. The reliability factor has to be more than 15 to be reliable. Then catch trials are similar to the global reliability indices. Then we have another metric here as mean sensitivity, which is inverse of mean deviation. So the mean sensitivity higher means the patient's fields are good, and the mean deviation is similar to the mean deviation of the Humphrey, and square root of loss variance is similar to PSD in the Humphreys. Then we have this Baby's curve, which is a defect curve. So what is done here is all the points are linearly arranged from worst to best, from best to worst, from left to right. So all the worst points will go to the one end here, and the best points will come here. So all these points are just arranged based upon their sensitivity in a linear manner. So this is the normal Baby's curve we have, which is between the 5 and the 95%. If all the points are depressed, which is called a generalized depression, all the points would go down. If there is a focal defect, there will be a cluster of depressed points to be represented on the right side of this plot here. And if there is a generalized depression along with the focal defect, it will look something like this. So in the end, I would just like to say it is important to interpret the fields very correctly. It's very important, but it is also more important to correlate them with the clinical picture of the patient. Thank you.
Thank you, Dr. Patel, for such an elaborated yet precise presentation. And with that, I would request Ronnie sir to give a few lines about the 24-2C. All of you would have heard about it, so I was going to just clarify that.
Yeah, so one of the disadvantages of the Humphrey parameter as compared to the Octopus is that it tests fewer points in the central area. And therefore, if you want to look at the central detail, you have to do a 10-2. The 24-2C actually tests additional points in the central area with the normal 24-2 program, and that gives you the additional information. So that's a benefit of the universal version.
The last speaker for today's session, that's Dr. Pallavi, who is going to tell us about interpreting posterior segment OCT in glaucoma.
Good afternoon, everyone. First of all, I would like to thank AIOC for this opportunity to be part of this subspecialty capsule. So my topic is role of posterior segment OCT in glaucoma. So OCT is a subjective and quantitative evaluation of the neural structures that are affected in glaucoma, that is the macula, the RNFL, and the optic nerve head. Previously, time domain OCT scans had an axial resolution of around 10 micrometer, but in ST OCT it has become almost 5 micrometer with better resolution. So ST OCT increased reproducibility, accuracy, and improved scan density, and it also reduces the artifacts and the scan acquisition time. So I had this case in my OPD where I could see a patient with having some inferior rim thinning, as can be seen in this. And there was also a broad RNFL defect. So I did an HVF for this patient, but as you can see that the HVF was almost normal. Though OCT was also done, and then finally it showed some inferior thinning, which can be seen in the sector analysis, and also in the macular analysis we can see some areas of ganglion cell thinning. So a diagnosis of glaucoma, we have to remember that it often precedes the vision loss. The standard automated perimetry is used for diagnosis, staging, and monitoring, but it is only likely to detect once the RGCs are lost up to 40%. So visual field testing is often variable and it requires repeated testing. So SD-OCT is the most commonly used, and there are Cirrus, Spectralis and RTQ, the main machines that are being used. This table shows the difference between the three machines. I'm not going into details due to lack of time. So what are the OCT parameters that we have to study, look for in a patient? So it's like peripapillary RNFL, the macular parameters, and the optic nerve head parameter. So the SD-OCT RNFL thickness, we can see the spectralis image. It represents the ganglion cell axons which enter the disc. The loss of RNFL can be seen in the red-free photos, but it is quantified with OCT. It's having good diagnostic accuracy. It quantifies the severity stages and differentiates normal from glaucoma in early stages. So this is the Cirrus HD-OCT and optic nerve head analysis report. So first is the key parameters in the table that is marked as 1 in the slide, and then there is a retinal nerve layer thickness map, which is a topographical display of RNFL, and in the hourglass shape of yellow and red colors is supposed to be normal. Then we have the thickness map, the deviation map, the NRR thickness, the RNFL thickness profile and average in global and sector thicknesses, which all can be seen. Color coding, we all know green is normal, yellow is borderline, and red is abnormal. This is the optic nerve head analysis. It is based on patient's age and the disc size, but we don't go in details in this because the disc size varies between the population. Also, there is torsion, tilt, and peripapillary atrophy. So, what are the RNFL parameters for diagnosis? It is the average circumpapillary RNFL thickness and the inferior sector RNFL thickness, which has having the best diagnostic accuracy. Next is the superior quadrant thickness values. And when we compare both the eyes, the inter-eye difference, if it's more than 9 micrometer, this also suggests an RNFL thinning and early damage. Now we have to keep in mind the artifacts. There can be something like segmentation errors when there is inaccurate delineation of the anterior and the posterior RNFL boundaries. So false decrease can be because of media opacities, cataracts, and vitreous debris. And green disease can happen when there's false increase. Can be because of myelinated nerve fibers, epiretinal membrane, and swelling of the optic nerve head. So more artifacts, this scan shows a decentration. So some of the areas more commonly seen in the myopic eyes, they will present with red, and this is also known as the red disease. So once the scan is repeated with proper centration, the defect corrects. Next, moving to the evaluation of the macular region. So, glaucomatous damage of the macula is difficult to detect on automated perimetry. It's often missed in evaluation of OCT when you're just looking at the circumpapillary RNFL. So, why should we study the macula? Because it has the maximum quantity of the RGCs, almost 50%. Then, unlike the optic nerve and peripapillary region, the macula is comparatively uniform in the patients and the measurements are more repeatable. So, in healthy individuals, there is greater or larger superior-inferior asymmetry between the patient and also in all individuals. And there is also less impact of blood vessels. So, in macular area compared with the RNFL. So, what are the diagnostic and scanning protocols? First, we look at the Cirrus. It's like they're measuring the GC-IPL, the ganglion cell layer, and the IPL. The Spectralis has a posterior pole asymmetry analysis, and the RTView has GC-IPL along with the RNFL also. So here we can see an image of the macular analysis, the ganglion cell, and generally it will have an uniform oval appearance if it is a normal eye. But in cases of glaucomatous damage, the hallmark is a loss infratemporal, as we can see in the picture. This is correlating with the deviation map, which is showing inferior thinning and also in the sectors in the right eye. So this is known as the squeaky sign, and this horizontal point is that we can see is the horizontal raphe. So generally, as we can see in this, we can see that there is inferior temporal thinning, which is correlating with the red areas on the sector analysis in both the eyes. And this is the hallmark, which is also correlated with the visual field, which shows a superior defect. So what can be the artifacts in the macular scan? There can be segmentation errors, decentration, or values below 40. And of course, in patients having ARMD, ERM, CME, macular thickness analysis should not be done. So next we move on to detecting progression. So for assessing progression, we have to keep in mind some things like normal attrition, the RNFL attrition and the other things like thinning due to normal aging, the floor effect, the thinning suggestive of glaucoma progression both globally and within a sector, and correlation of RNFL loss with the visual field loss. So RNFL thinning in normal healthy eyes will have around minus 0.48 micrometer per year. This is seen in the Cirrus machine. And in glaucoma progressors, this value can increase up to minus 0.98. And also similar values are shown in spectralis. We should keep in mind the floor effect, which means that the RNFL never goes to zero. That is happening because of Muller cells, astroglia, microglia, and the blood vessels, which do not degenerate completely. Hence, we can see that all the areas over here are red marked, but none of the values are going beyond, going lower than 40. So the floor effect is also shown over here in the various machines, and then we cannot, progression can still occur, but we cannot depend on this. We have to go for a macular rosity or HPF 10-2. So progression analysis can be event-based or trend-based. It measures the difference between baseline. Event-based measures the difference between baseline and the current value. Decrease more than 5 micrometer is suspicion, and if it's around 7 to 8 micrometer, it is definitely suggestive of progression. In a trend-based analysis, we just monitor the slope of the RNFL thickness over time. So this is the GPA printout. It's divided into 4 parts, and I'll go part by part to explain. So the first is the deviation map. It shows change that are statistically significant. It is seen as areas marked in orange, and then subsequently it is shown as marked in red. These graphs show the average RNFL thickness. Here also we can see that the first average superior and inferior. The first significant change is shown as orange and dot, and then the subsequent changes are shown in red. This RNFL thickness profile compares the current visit, that is a C, with B1 and B2, and here we can clearly see that there is some thinning in the inferior zone in the profile. So the GP analysis is a summary of RNFL and optic nerve head summary parameters, and we see that the first significant change is marked as orange, and then the subsequent ones are in red. So average, RNFL, inferior, superior, all are showing thinning. So progression monitoring with macular rosity, we have to remember that in the normal values around 82. Now these are just guidelines I'm giving. They're not absolute, but you have to use them to assess the progression in patient. So supranasal part is the thickest, and the macular GC IPL will decrease at the rate of around 0.31. That is a normal attrition with aging. And in early glaucoma it reduces to around 75. In moderate it goes up to 64, and then in advanced it may drop down to 55. So if the change is more than 4 micrometer, then it is suggestive of progression. So difference in machines we have to keep in mind. If we use RGView, it generally gives us hither value. So if we use it to assess progression, we get false data. To summarize, OCT is a powerful objective structural assessment tool that can greatly assist in clinicians in diagnosing and managing glaucoma, and monitoring progression by OCT has also is a good quantitative and reliable tool. We should always use it with the clinical evaluation and visual field testing. In early glaucoma, OCT of RNFL and macula is important, and we should always watch out for the acquisition errors and artifacts. Thank you for your kind attention.
When the higher false positive rates with the structural test, how do we differentiate prepigmented glaucoma and red disease?
Through the overall evaluation, so we should not miss the basic findings. We should do a proper disc evaluation, a proper perimetry, and then correlate that with your OCT findings. Then we can avoid making mistakes with red disease or it.
Thank you, ma'am. So also, I would like to ask, with the upcoming machine learning strategies and artificial intelligence, will it minimize the role of glaucomatologists, or will it add value to the practice? Sir, can you please answer the question?
Well, if you look at all the AI things that have come out so far, they have come out for the easy stuff. They have come out to detect diabetic retinopathy, which is there or not there. Any of us saying you can do it. The machines also do that very well. The moment you say glaucoma, the big problem with this, and we are working with 2-3 groups on it, is defining what is actually disease. We are ourselves not sure of how to define disease. I don't think the machine is going to do much better.
Thank you very much. With that we come to the end of the session, and I will request all the speakers and chairperson to come on the dais for a group photograph. Thank you very much for being with us. I'll share it with you.
They're supposed to finish at 1:30. Might be after.
Yeah, thank you.